The following week we'll be talking about venous thromboembolism. So that's the topic for today, and I'm sure you may have read something similar on it. So as much as possible, let's all try and contribute during the discussion. All right. So basically, when we say venous thromboembolism, what does it mean? If we break it into syllabi, we have venous, we have thrombo, we have embolism. What does it mean? Who can set the tone for us? So as much as possible, let's all try and contribute during the discussion. All right. So basically, when we say venous thromboembolism, what does it mean? I believe you can hear me. Break it into syllabi. We have venous, we have thrombo. Hello, can you hear me? What does it mean? Who can
Hello, Dr. Ishak.
Yeah, can you hear me?
Yeah. Yes. So, with
So,
venous thromboembolism, it's usually about occlusion in either deep or superficial veins. And usually the types we have are deep vein thrombosis and also PE. So that's what I read about venous thromboembolism. Hello, Dr. Ishak.
okay, so that's good.
Can you hear me? Yeah.
So when you break it into
So, with venous
the various syllabi, you realize you are dealing with the venous
usually
system.
about occlusion
Unlike the
either
peripheral
deep
vascular
or
disease, when we're looking
superficial
at both
veins.
the arteries
And
and the
usually the
veins.
types we have
But
are
for venous
deep vein
thromboembolism,
thrombosis and
our
also PE.
concern is
So
with the veins.
that's what I read
And we are
about
saying you could have
venous
a
thromboembolism.
thrombus and you could also have an embolus or emboli. So basically, in simple terms, when you talk about a thrombus, that's a clot being formed within a vessel. So the clot is formed in situ
And
within a
the types
vessel.
we have
So there was, say, an endothelial injury, and you have platelets aggregating there, you had clotting factors all aggregating to form a clot. That was a platelet, or that was a clot that was formed in situ. So that's a thrombus. In the same way, for an embolus, embolus,
so
the clot is formed in situ, part of the clot can
within
break
a
up,
vessel.
or the whole there was, say, an endothelial injury and gets into a distant vessel.
Clotting
So
factors
if
all
you have a
aggregating
clot
to
moving
form a
from
clot.
its
That
original
was a
location to
platelet,
block a
or that was
distant
a clot
vessel,
that was
that clot is termed an embolus. So some use the term a moving thrombus or a migrating thrombus. So that is an embolus. So for venous thromboembolism, we are either dealing with a thrombus within the veins or an embolus within the veins. And VTE, or venous thromboembolism, is subdivided into two. So we could have DVT, which is deep vein thrombosis, or we could have pulmonary embolism. So take note of that. So in terms of the clinical syndromes or clinical disease that can come from a thrombus or embolus blocking a vein, you can either have a DVT, where it's blocking the deep veins usually within the extremities, or you could have an embolus that has migrated from a DVT and getting dislodged in the pulmonary vessel. So that's P. So take note of that. So before we talk about this in detail, let's talk about the veins. So what do you know about the veins? What do the veins do in the body? Anyone to help us? What's the function of veins in the body?
carrying deoxygenated blood.
Yeah, so they help carry deoxygenated blood back to the heart. And these veins do this against gravity. So because it's against gravity, they are supported by valves. So you have these structures within the veins to support blood or venous return back to the heart. So when you compare that to the arteries are rather sending oxygenated blood to all parts of the body. But when you look at the veins carry deoxygenated blood back to the heart, and they do it by the help of valves. What again do we know about the veins? In terms of blood flow in the veins, how is the nature like compared to the arteries? Does blood move very fast within the veins or move slowly within the veins in terms of blood flow?
Flows slow through the veins. It moves at a lower pressure.
Anyone? Is anyone helping us?
Blood flow is slower through the veins. In the veins, blood flow is at a lower pressure.
Yeah, so blood flow is slower within the veins compared to the arteries. So usually the arteries are referred to as the fast flowing vessels, whereas the veins are the slow flowing vessels. So in terms of blood flow, it's very slow. So let's take note of that. And the other thing I want you to take notice, because blood flow is very slow, if there is any condition that sort of further aggravates blood flow moving very slowly, maybe you are bedridden, you have paralysis and all that, blood becomes stagnated for some time, and that can lead to thrombus formation. But this thrombus formation, you would have to know that it's different from the arteries. When you have an occlusion within the arteries, you could have thrombus formation. If you have atherosclerosis, atheroma forming and all that, you could also have thrombus formation. So this compared to the arteries. Then aside that, when you look at the blood that's flowing within the veins, in terms of clotting factors, in terms of platelets, when you look at blood that is flowing within the veins, it tends to be high in clotting factors. So you have a lot of clotting factors, you have a lot of fibrin within the veins. When you compare that to the arteries, the blood flow that occurs is fast, and in terms of the nature, is platelet rich. You have a lot of platelets. So when there's an endothelial injury within the arteries, what happens is you have platelets aggregating around the site. And once platelets aggregate around the site, you can have thrombus formation. And this thrombus that is formed is high in platelets. And because of that, such thrombus are termed white thrombus. So that's the name given to thrombus that are formed within the arteries. We call them the white thrombus because they are platelet rich. The same way, when you look at the veins, we say blood flow is slow. In terms of the blood, the nature is more rich in clotting factors and fibrin. So when there is blood stasis, there could be clot formation. And this clot formation occurring in the veins is usually rich in fibrin. So we usually term it the red thrombus. So red thrombus in the veins, white thrombus in the arteries. And because the nature of the thrombus are different, It also implies that the treatment will also be different. So if you have arterial thrombosis within the arterial system, we tend to use antiplatelets like aspirin, clopidogrel, and all that because that clot is rich in platelets. So we use antiplatelets. Whilst when you look at the veins, because the clot is rich in clotting factors and fibrin, we tend to use anticoagulants. And this is because they can target specific clotting factors within the pathway. So that is the more reason why for conditions like DVT, PE, we'll be using anticoagulants. And conditions like coronary artery disease, stroke, we'll be using antiplatelets. Are you okay? Can we move on?
Hello, Doc. Please can you take that last part again?
You said?
Again. Can you please take the last part again?
Yeah, so the last part I was talking about the type of treatment. So I said for the veins, because the clots are rich in fibrin and clotting factors, we tend to use anticoagulants. Whilst for the arterial system, because the clot is rich in platelets, we tend to use antiplatelets. And this is the more reason why conditions like DVT, we use anticoagulants. Then coronary artery disease, stroke, these usually affect the arteries. So we use antiplatelets.
Thank you.
Okay. Any more questions? All right. So that was just a brief introduction. So because we are looking at the veins, you should understand the location of the veins. So usually DVT, I said, would affect the extremities. And the extremities that are most affected are usually the lower extremities. That is not to say you can't have DVT within the upper extremities. It's very rare, but it can happen. Just that most cases you would have DVT occurring within the lower extremities, so the limbs, the legs. That is where you have DVT occurring. So for that reason, DVT is subdivided into two, depending on the location of the clot forming. So we have what we call proximal DVT, and we have what we call distal DVT. So proximal DVT and distal DVT. So we're looking at the names. What do you think proximal DVT would be? And what do you think distal DVT would be? Anyone to try? Anyone? All right. So looking at the names, you are saying one is proximal and the other is distal. So when you have DVT, what you are usually concerned about is the risk of embolization of the clot to the heart and finally getting to the lungs. Because you know the veins carry the oxygenated blood back to the heart. So if there was a clot and that clot has embolized, it can get to the heart. And once it gets to the heart, because it's deoxygenated blood, that blood will be pumped through the pulmonary vessels to the lungs to be oxygenated. So if you have a clot in there, it can block the pulmonary vessel leading to PE. So that is what we are afraid of. So because of that, we are looking at proximity to the heart and lungs. So we are looking at proximity to the heart and lungs. So when you look at the leg, if you have a clot forming within the legs that is above the knee, then we are looking at a proximal DVT. So if you have a clot within the legs which is above the knee, that is close to the heart and lungs compared to something below the knee. So such DVT are termed proximal DVT. If you have the clot forming within the vessels, the veins below the knee, such DVT are termed distal DVT. So these are the two main subclassifications. We have proximal DVT and we have distal DVT. And it's very important to note whether the DVT is proximal or distal, because when it's proximal, you are more concerned because it's very close to the heart and lungs. The risk of patient getting PE is high, and PE is a medical emergency. Once the patient gets PE, they can die within seconds. So because of that, they are usually concerned about proximal DVT compared to distal DVT. That is not to say you shouldn't be concerned about distal, but in terms of risk of embolization, there is a 50% higher chance of proximal DVT leading to PE compared to distal DVT. So when you look at percentage-wise, there's a 50% higher risk of a proximal DVT leading to PE compared to a distal DVT. So usually more concerned about proximal DVT compared to distal.
Hello,
All
sir.
right. Yeah.
Please, can you take the two types of DVT again? I didn't get that.
So I said proximal DVT is having a thrombus within the legs that is above the knee. So if it's above the knee, then it's a proximal DVT. If it's below the knee, then it's a distal DVT. And we are saying that's because of proximity to heart and the lungs. Because we are concerned about PE, if it's close to the heart and lungs, then we term it as proximal DVT. If it's further away from the heart and lungs, which is below the knee, it's termed as distal DVT. And I said there's a 50% higher risk of a proximal DVT leading to PE compared to a distal DVT. So for that reason, you may have a patient who has contraindications to the use of anticoagulants to manage the DVT. But because the patient has proximal DVT, you may try to stabilize. Maybe the patient was bleeding, you may want to stabilize the bleeding and initiate your intervention for proximal DVT. But for distal DVT, you are not really concerned that much because the risk of leading to PE is relatively lower compared to this proximal DVT. Any other questions? All right. So after knowing the two subtypes, depending on the proximity to the heart and lungs, you should know some of the veins that are involved within the proximal DVT and some of the veins that are involved within distal DVT. Sorry that if they do a Doppler and they say patient has a tibial vein thrombosis or patient has iliofemoral DVT, you should understand the risk involved, whether it's a proximal, whether it's a distal, and the risk involved. So, what are some of the veins that are implicated in proximal DVT? So, which veins are involved for proximal? So, look at veins that are above the knee. So, which veins?
Femoral vein,
Yeah, so the femoral vein. Femoral vein. Okay,
popliteal
what
vein,
again? Yeah, so popliteal vein. So you have femoral vein, you have popliteal vein. What again?
The iliac vein.
So the iliac vein. The iliac vein. So these are the three main veins that are involved in proximal DVT. So the femoral vein, the iliac vein, and the popliteal vein. So when they do a Doppler and you see popliteal vein DVT, you should know that it's a proximal DVT. Or iliofemoral DVT, you should know it's a proximal vein DVT. What about the distal vein?
Yeah, please, your line was breaking. I couldn't hear you.
So I said proximal DVT. We have femoral, we have iliac, and we have popliteal. So femoral, popliteal, and the iliac. That's proximal DVT. So for distal DVT, what are the veins involved?
Tibial vein.
So distal DVT, we are looking at the veins below the knee. So which veins are below the knee?
The tibial vein.
So we have what we call the anterior tibial vein. So the anterior tibial vein. So the tibia. So there's an anterior tibial vein. So if we have anterior tibial vein, the next one will be what?
Posterior.
Exactly so. So we have posterior tibial vein. So we have anterior tibial vein, posterior tibial vein. What again? So we have what we call the muscular vein. Muscular vein. So just like muscle, muscular. So muscular vein. And we have the peroneal vein. The peroneal vein. So peroneal. So these are the four veins involved in distal DVT. The anterior tibial vein, the posterior tibial vein, the muscular vein, and the peroneal vein. So when you have an ultrasound report saying posterior tibial vein DVT, then you know you are dealing with a distal DVT. And the clinical significance is the risk of embolization from a distal DVT is 50% lower compared to a proximal DVT. So we'll be more concerned with a proximal DVT compared to a distal DVT. All right. So any questions before we move on? Okay. So after knowing this, we'll talk about a brief pathophysiology of deep veins thrombosis. So that's what we are moving to. So the pathophysiology of DVT or venous thromboembolism. All right. So for the pathogenesis of DVT is very simple. It hinges on three main things. And this is a clinical triad of symptoms or clinical triad of conditions. And when you have the interplay of these three conditions, then you can have a clot forming within the veins. And these three clinical conditions come together to form what we call the Virchow's triad. So the Virchow's triad. So it's a triad of three clinical conditions. And when you have these three conditions being present, it means you have a triad. And that triad is what we call the Virchow's triad. So we take them one after the other, then we talk about them. So picture it like a triangle. So we have an endothelial injury. So if you have endothelial injury, it can predispose you to getting clot within the veins. Then the other thing is blood stasis. So blood stasis. And the last one is
Sir, please, I don't know if I'm the only one,
hypercoagulability.
but your line is breaking.
Is it for everyone or it's just you? Hello, can you hear me?
Yes, please.
So for virtual triad, I'm saying we have interplay of three main things. And these three things come together to form what we call the triad. So it starts with endothelial injury. You could also have blood stasis, and you could also have hypercoagulability. So these three things come together to form the Virchow's triad. And the formation of clots within the veins hinges on these three things. So whenever you have endothelial injury, it can predispose you to getting a clot. Whenever you have blood stasis, it can predispose you to getting a clot. The same way when you have hypercoagulability, that can also predispose you to getting a clot within the veins. Even though we are talking about a triad, it doesn't necessarily have to be all these three being present before you can have a clot within the veins. It could just be blood stasis, and that can lead to clot. It could just be endothelial injury, that can lead to clot formation, or it could just be hypercoagulability. All of them can be on a standalone to cause clot formation. However, if all the three are present, then that's what we call the Virchow's triad. So let's take them one after the other. So we'll start with endothelial injury. Endothelial injury. So when you look at the blood vessel, the inner lining of the blood vessels are the endothelium. So that inner lining you see within blood vessels, the endothelium, and it's made up of layers. The innermost being the tunica intima, followed by the middle layer, which is the tunica media, and the outermost being the tunica externa. So these are the layers of the endothelium. So what happens is when there is an injury to the endothelial lining, the body tries to repair that injury. And usually what will cause an injury to the endothelium is maybe there's a surgical procedure where there's a cut through the tissues that can cause damage to the endothelial lining. You could also have hypertension causing shear stress. So when the blood pressure is high, it could cause shear stress to the endothelial lining. You could also have smoking. Smoking is one of the major cause of endothelial injury, and that drives atherosclerosis and all that. So whenever you have injuries in the endothelium, what happens is the body tries to repair itself. So the responses, you have migration of platelets, you would also have migration of inflammatory mediators and all that. You would also have fatty streaks deposition. All these are happening at the same time. And eventually, you also have clotting factors migrating to that area. So when all these happen, you can have clot formation. So the platelets could aggregate, the clotting factors can also be activated to cause fibrin deposition. So fibrin sort of stabilizes the plaque that has been formed. And that's when you have a clot being formed within the vessel. So endothelial injury is one of the major cause of venous thromboembolism. So a lot of conditions can predispose you to getting endothelial injury. The next one is blood stasis. And from the name, stasis means you have stagnant, you have something being stagnant. And in this case, you are talking about blood. Already, we know that blood flow within the veins is very slow. So if there is any damage to maybe the vessels or maybe the valves, maybe there's a condition that predisposes you to having very slow moving blood, like being bedridden for some time. Blood becomes stagnant within the vessels. Once blood is stagnant within the vessel, you have accumulation of clotting factors. So clotting factors can aggregate at a point to cause a clot within the veins. So any condition that predisposes you to a stagnated blood can cause VTE from blood stasis. And the last one is hypercoagulability. For hypercoagulability, basically what it means is the blood has become thicker than it's supposed to be. So hypercoagulable state. So the blood has become thicker than usual. And this is usually because in a normal system, we have what we call procoagulants and we have anticoagulants. So ideally, the body's natural procoagulants are the clotting factors. They predispose you to getting clot within the vessel. And we have body's natural anticoagulants, like the protein C, the protein S, antithrombin 3. These are body's natural anticoagulants. And they are supposed to keep the procoagulants in check. So they are usually in a form of an equilibrium so that you have enough anticoagulants to check the procoagulants. So if you have a lot of the procoagulants, that means it will tip the balance to a hypercoagulable state. In the same way, if you have low levels of the anticoagulant, body's natural anticoagulant, it can tip the system into hypercoagulable state as well. So all these three come into play to cause the thrombus we see in DVT and P. And these
Hello,
three
Dr.
are very
Ishak.
important. Hello.
Hello, Dr. Ishak. Could you kindly take the procoagulants and the anticoagulants again?
Yeah, so for hypercoagulability, I'm saying when you have blood being thicker than normal. So usually in the system, you have body's natural procoagulants and the body's natural anticoagulants. The procoagulants are supposed to increase your risk of thrombosis. So they are usually the clotting factors. And the body's natural anticoagulants, we have protein C, we have protein S, we have antithrombin 3. These are body's natural anticoagulants. Ideally, they are supposed to keep the procoagulants in check so that the balance is always in equilibrium. We have some equilibrium in the system. So if you have more clotting factors being activated, that means the equilibrium will shift towards the procoagulant. So you are likely to have clot formation. In the same way, you could also have the body's natural anticoagulants going low. If it goes low, it also tips the balance into the procoagulant. So you can have the clot being formed. So that is how hypercoagulability comes about. You have either high procoagulants or you have low anticoagulants. Any questions?
No, please. Thank you.
Okay, all right. So all these three come into play to form what we call the virtuous triad. And basically, any clot that will form within the deep veins or in P comes about through virtuous triad. So you should know some of the risk factors that can predispose you to hypercoagulability, to blast stasis, and to endothelial injury. So that's the next thing we'll be talking about, risk factors for VTE. So the risk factors for venous thromboembolism. And for the risk factors, they are usually grouped into three. So when you look at the risk factors, they are usually grouped into three for VTE. You have the weak risk factors, you have the moderate risk factors, and we have the strong risk factors. So in terms of the risk factors, we have weak risk factors. So it's based on severity. The weak risk factors, we have the moderate risk factors, and we have the strong risk factors. So we talk about some of the risk factors and we'll classify them under weak, moderate, or strong risk factors. So what are some of the risk factors you know for DVT? So looking at the virtuous triad. So you said endothelial injury, blastasis, hypercoagulability. So what are some of the risk factors that can predispose you to getting this?
Hospitalization for more than 2 weeks.
Hospitalization for more than 2 weeks. Okay, but if the patient is hospitalized, then the patient is ambulatory. So that means the patient is not bedridden in bed, but is hospitalized. He walks about in the hospital and all that for more than 2 weeks. Do you think the patient will develop DVT?
No, please.
Yeah, so it's not just being hospitalized, but if you are bedridden. So if you are bedridden for more than 3 days, you have a risk of getting DVT. So bedridden for more than 3 days. So that is the more reason why when patients are admitted, usually for more than 3 days, they start DVT prophylaxis because the risk of getting DVT after 3 days become high if they are bedridden. But if they are ambulatory, they are hospitalized, such patients may not need DVT prophylaxis. But if they are bedridden, they are always lying in bed 24/7. for more than 3 days, that's a risk of developing DVT. So usually put them on DVT prophylaxis. And bedridden, you know very well when you are bedridden, that means blood will find it difficult getting back to the heart because already there's slow movement of blood within the veins. And you are also bedridden. In terms of activity, there is no activity to help the veins push blood back to the heart. So you are likely to have blood stasis. So bedridden is one of the major causes of blood stasis, and that can cause DVT. So when you look at the classification, bedridden for more than 3 days is classified as a weak risk factor. So a weak risk factor for DVT. So take note of that. So they usually like asking these questions. Maybe all the following are strong risk factors for DVT, except you should know the ones that are weak, moderate, and the strong. So bedridden for more than 3 days is a weak risk factor. What again? Any other risk factors?
Smoking.
You said?
Smoking.
Yeah, smoking. You said smoking can predispose you to DVT. And usually smoking does this by causing endothelial injury. So in terms of the virtuous triad, smoking causes endothelial injury. And once there's endothelial injury, you have platelets, you have clotting factors, inflammatory mediators, and all that migrating to the site. And that can cause DVT. So smoking is also one of the risk factors. Usually a weak risk factor for smoking. What again?
The use of oral contraceptives.
Yeah, so oral contraceptives. So usually these oral contraceptives can also predispose you to getting DVT. And because these contraceptives, you have a lot of them containing estrogen. Usually the estrogen based ones tend to predispose you to getting DVT. And when you look at the virtuous chart, these contraceptives increase your procoagulant. So they increase your procoagulant levels. And once procoagulants are increased, it tips the balance to a hypercoagulable state. So you may develop DVT from oral contraceptives because the procoagulants have been increased compared to the anticoagulant, body's natural anticoagulant. So it's usually classified as a moderate risk factor. So usually oral contraceptive, aside oral contraceptive, you could also have hormone replacement therapy. So patients who are on hormone replacement therapy, usually postmenopausal women, after menopause, they tend to get these menopausal symptoms. So they may be put on hormone replacement therapy. And usually these are estrogen based ones. That can also predispose them to getting DVT. And it's the same mechanism, increasing your procoagulants compared to the anticoagulants. All right. Any other risk factor?
Having surgeries, especially the orthopedic ones.
Yeah, so surgery is also one of the major risk factors. So depending on the type of surgery, usually surgeries, they use these scalpel and all that. It can cut through the veins. And once you have veins being cut through, definitely the endothelia would also be damaged. So usually surgeries will cause endothelial injury. Aside that, right after surgery, the patient may be immobile in bed, and that can also predispose them to blast stasis and also getting clots being formed. So depending on the surgery, you may have it being classified as a strong risk factor or a weak risk factor. So if you are having major orthopedic surgery, like a knee surgery, a hip replacement surgery, these are major orthopedic surgeries. And these are strong risk factors. So when you undergo a hip replacement therapy, a knee replacement therapy, all these are orthopedic surgeries. So they are strong risk factors. Or you could also have a major general surgery. So a major general surgery where they are cutting through a lot of organs and a lot of tissues. And the patient requires general anesthesia and all that. So such surgeries, major general surgeries, also are classified as strong risk factors. But when you look at a surgery like cholecystectomy, this is a laparoscopic surgery. So for laparoscopic surgeries like cholecystectomy, they are classified as weak risk factors. So the weak risk factors like laparoscopic surgeries are example is cholecystectomy. These are weak risk factors. Then major surgeries and major orthopedic surgeries are strong risk factors. So depending on the type of surgery, it can be a weak risk factor or a strong risk factor. What again?
Trauma.
Trauma.
Yeah, trauma. So trauma. Usually trauma that leads to fractures. So if you have fractures of the hip, fractures of the leg and all that, that is a strong risk factor for DVT. Well, usually such patients after the trauma may become immobile in bed for a long time, and that predisposes them to getting DVT. And the site of fracture, we could also have clots being formed within that site. So that's a strong risk factor. Fractures or trauma, strong risk factor. What again?
Pregnancy.
Yeah, pregnancy. Pregnancy is also one of the risk factors for DVT. So, once you become pregnant, you have distended abdomen and all that. And that distended abdomen can press on the lower veins. So it can press on your iliac vein, the femoral vein, and all that because of the increased lower abdominal pressure. And once there's pressure on these veins, you have difficulty of blood returning to the heart. So blood can pool in the lower extremities. You can have clots developing there. So that is even the more reason why these pregnant women usually develop varicose veins and pedal edema, clots because of the increased lower abdominal pressure on the venous system. Aside that, there could also be increased procoagulants compared to the body's natural anticoagulant. That can also predispose them to getting DVT. So usually depending on the stage of the pregnancy, it can be a weak risk factor or a moderate risk factor. So usually antepartum. So during the antepartum stage, so that's before delivery. So during the antepartum stage, before delivery, that is classified as a weak risk factor. But postpartum stage, so just after delivery, that is the postpartum stage of pregnancy. That is classified as a moderate risk factor. Just after delivery, postpartum, the patient will be bleeding, the baby will be out, they are cutting the umbilical cord, removing the placenta. So because of the bleeding, postpartum bleeding, the body tries to stop the bleeding, so there will be clot formation. And depending on the the nature of the bleeding, the patient may have a lot of clots being formed and they may end up developing DVT. So postpartum stage is classified as a moderate risk factor, but the antepartum stage before delivery is classified as a weak risk factor. So take note of that. So depending on whether it's antepartum or postpartum, it can be classified as a weak or moderate risk factor. Any other risk factors?
Obesity.
Yeah, obesity. Obesity, just like pregnancy, you have usually central obesity, and that can put pressure on the venous system. So obesity is classified as a weak risk factor. So it's one of the weak risk factors for DVT. Any other?
Doc, please, can long sitting also be a risk factor?
Yeah, so in terms of air travel or traveling by road, so maybe you are traveling by flight and you sat down in the plane for a very long time. When you woke up or when you got down, you could. So you've heard of instances where people have traveled and when they got down, they started feeling breathless. They rushed them to the hospital and they realized the patient had developed PE and died. So distance can predispose you to getting DVT, especially when you are sitting for long. When you are sitting for long, you are immobile, and because of that immobility, you could have blood stasis and you could have clot formation. So immobility from sitting for long, usually prolonged car or air travel, can predispose you to getting DVT. And this is classified as a weak risk factor. So immobility due to sitting can be classified as a weak risk factor. Any other?
Chemotherapy.
Yeah, chemotherapy. So the chemotherapy that is given when you have cancer, cancer itself, malignancy itself, is a risk factor for developing DVT. And this because when you have cancer, cancer increases your cancer, you have rapidly dividing cells. And during that stage, you also have a rapid increase in the body's natural procoagulant. So the procoagulant factors increases. So the clotting factors tend to be activated. You can have clot formation. So when there's malignancy, malignancy is a moderate risk factor. And the chemotherapy that is used can also predispose you to getting DVT. That is also classified as a moderate risk factor. So cancer itself is a moderate risk factor. Chemotherapy is also a moderate risk factor. What again?
Age.
Yeah, increasing age. The more you age, the more your risk of developing DVT become high because the vessels are usually occluded. Whilst you are aging, you are having atheromas forming, you are having endothelial injury and all that. That can predispose you to getting clot compared to someone who is younger. So increasing age is a weak risk factor. So in terms of the severity, is classified as a weak risk factor. What again?
Hypertension.
So hypertension. He said hypertension can cause shear stress to the endothelial lining, and that can predispose you to getting clots. And aside hypertension, we have other medical conditions. So usually the medical conditions are classified as moderate risk factors. So something like heart failure. Heart failure, you have reduced ejection fraction. And because of the reduced ejection fraction, you have more blood staying within the chambers. So the residual volume increases. And once the residual volume increases, you can have blood being stagnated. And because of that, clots can be formed. And that clot can easily be dislodged to other parts of the body. So heart failure is a moderate risk factor, hypertension, moderate risk factor. If you have stroke, stroke usually presents with weakness. So the patient may develop hemiparesis or hemiplegia. So because of that, the patient may be bedridden for some time. So that is also a moderate risk factor. So usually the medical conditions like hypertension, heart failure, stroke, cancer, they are all classified as moderate risk factors. And you could also have congenital conditions. So maybe you have issues with, say, thrombophilia. You have a lot of these platelets. So you can have thrombophilia. So that can also predispose you to getting clots. So that is a moderate risk factor. You could also have patients with respiratory conditions. So chronic respiratory conditions, usually something like cystic fibrosis. Cystic fibrosis is also one of the medical conditions that can predispose you to getting clots. And that is also classified as a moderate risk factor. So usually the medical conditions are moderate risk factors. Then we could also have varicose veins. You remember when we were talking about peripheral vascular disease, we said for varicose veins is one of the causes of peripheral venous disease, where there's over-distended veins and they appear as rope-like on the legs. So that is a weak risk factor. So if you have varicose veins, you are predisposed to getting DVT because venous return reduces and blood can be stagnated there and clots can form. So it's also classified as a weak risk factor. Then some of the strong risk factors we've mentioned trauma like fractures, we've mentioned orthopedic surgery, major general surgery. You could also have a spinal cord injury. So if you have a spinal cord injury, usually you may become paralyzed for life. Some can become paralyzed for life, and because of that, their risk for getting DVT is strong. So take note of that. So these are some of the strong risk factors. And we've mentioned some of the moderate risk factors and also the weak risk factors. So when you are looking at risk factors, always look at whether they are weak, moderate, or strong. Any questions?
Service, can you take the strong risk factors again?
So for strong risk factors, I mentioned major orthopedic surgeries like knee replacement therapy, or you are going for hip replacement surgery. These are orthopedic surgeries, and they are high or strong risk factors for DVT. You could also have major general surgeries where they've given general anesthesia, they are cutting through a lot of tissues. There can be endothelial injury, you have clot formation and all that. So that is a major general surgery which is also strong risk factor. Then I mentioned fractures. We have fractures to the leg, fractures to the hip. All these are bones. So once you have fractures in any of these areas, you can become immobile for some time, and that's a strong risk factor. Then when you look at um, so you could also have maybe trauma with multiple injuries. You were engaged in an accident, head-on collision, you sustain a lot of injury, maybe C-spine injury and all that, you are becoming immobile. That can also predispose you to getting DVT, and it's a strong risk factor. And the last one I mentioned was spinal cord injuries. So if you have injuries to the spinal cord, you can become paralyzed, and that's a strong risk factor. Any other questions?
Doc, please, what category will a family history of DVT fall under?
Okay, so if you have a family history of DVT, that's a weak risk factor. So family history of DVT is a weak risk factor. But if you've had a previous history of DVT, so maybe you have developed DVT before, you treated it, and now you've developed again, that previous history of DVT is a moderate risk factor. But a family history, maybe your dad had it, your mom had it, that's a weak risk factor. Any other questions? Okay.
Doc, how about nephrotic syndrome? Because I know it decreases antithrombin 3 concentration. So I'm wondering, would it also be a risk factor?
Yeah, so you could also have issues with the body's natural anticoagulant. So we mentioned protein C, we mentioned protein S, we mentioned antithrombin 3. So if we have deficiencies in these body's natural anticoagulant, it will tip the balance to the procoagulant side. So it will make your blood hypercoagulable. So that causes hypercoagulability. So you could have protein C and protein S deficiency. That's a moderate risk factor. And if you have nephrotic syndrome, so nephrotic syndrome is also a clinical triad. Others term it a clinical tetrad, where you are producing proteinuria or you're having proteins in urine more than 3.5 grams per day. And because you are losing protein, it's not just protein, but you also lose other proteinaceous substances like clotting factors and also body's natural anticoagulants like antithrombin 3. So you use body's natural anticoagulants like antithrombin 3 in urine, that will tip the balance to procoagulant. And once you have procoagulants more than body's natural anticoagulant, tips your balance to hypercoagulable state and you may have clots. So that is a moderate risk factor. Any other questions?
Yes,
All
please.
right. Someone has a question?
So please, how would you know if a condition is a moderate? Yes, please.
Hello?
I'm asking that how would you know if a particular hello?
Yeah,
Hello?
we can hear you.
Yeah, I'm asking how would you know if a particular condition is weak, moderate, or strong? Because probably we might not have exhausted all the risk factors. So when you identify a particular risk factor, how would you know if it's moderate, strong, or weak?
Yeah, so usually these have been stratified based on studies that have been done. So we look at the relative risk of the risk factors. So we are looking at the risk of developing DVT if you have this condition, the risk of developing DVT if you have if you are bedridden, if you have what do you call it, trauma, pregnancy, and all that. So all these have been risk stratified based on studies. So if you are looking at, say, um, something like major surgeries or major orthopedic surgeries, the number of people who underwent or who had major orthopedic surgery, how many of them developed DVT? Based on the number, it can be classified as a strong risk factor, weak risk factor, or moderate. The same way, if we look at something like varicose veins, how many people have developed varicose vein DVT from varicose veins? Based on the number of people, then it can be classified as a weak, moderate, or strong. So these have already been established. Do you get it? So try as much as possible to know the common ones. As I've said, most of the medical conditions are moderate risk factors. Most of the major surgeries are strong risk factors. Then the weak ones are something like being bedridden, immobility, your age, something you can't really control. Whilst you are increasing, your risk becomes high, but it's a weak risk factor. It doesn't mean that every elderly person would have DVT. So all these have been risk stratified already. Any other questions? All right, so let's move on. So at this point, we'll quickly talk about the clotting cascade because it's very important when it comes to the management. You should know where the medications, all the medications will be active for you to appreciate. Such that when we say Clexane acts around this side, you don't understand. When we say warfarin acts in this pathway, you would understand. So we'll talk about the clotting cascade. And usually the clotting cascade, we have two main clotting pathways. So we have the intrinsic pathway and we have the extrinsic pathway. These are the two main pathways, but they all end up in one common pathway. So that is added as the third pathway. So the common pathway, both intrinsic and extrinsic, end up in the common pathway. But if you are looking at the two main pathways, it's intrinsic and extrinsic. But they all end up in the third pathway, which is the common pathway. So we take them one after the other and go through what they are. So we'll start with the extrinsic pathway. So the extrinsic pathway. So if you look at the name, extrinsic, extrinsic means something outside. So what is happening is for you to have a clot forming within the veins, you should have a trigger from outside. And that outside trigger is usually trauma. So for extrinsic pathway, the trigger is trauma. So trauma is the trigger for extrinsic pathway. And these pathways are basically activation. You have activation of clotting factors. So we are saying that whenever there's trauma, trauma can lead to injury and all that. So when there's injury to the tissues, what happens is there's release of a substance called tissue factor. So trauma causes injury to the tissues, and once there's injury to the tissues, there's release of this factor known as the tissue factor. And this tissue factor is also known as thromboplastin. So that's the other name for tissue factor, thromboplastin. Whenever there's trauma, you can have injury to the tissues, and once there's tissue damage, there's release of this tissue factor or thromboplastin. What this thromboplastin does is it activates factor 7 to 7A. So what I need you to appreciate is the clotting factors are in the form of inactive, or they are in the inactive form. So all that we are trying to do is we want to activate the clotting factors. And the activated clotting factors, you realize that you have A attached to the name. So factor 7, when you hear of factor 7 is inactive. But the active one is factor 7A. So the A there means it has been activated. So what happens is for extrinsic pathway, we are saying that the trigger for extrinsic pathway is trauma. So whenever there is trauma to the tissues, there is release of a tissue factor, also known as thromboplastin. And what this thromboplastin does is it activates factor 7, which is inactive, to factor 7A. So that factor 7A is activated. So take note of that. Once factor 7A is activated, it also activates another factor. So it activates factor 10 to 10A. So once factor 7A is activated, it activates factor 10 to 10A. So this is a cascade. So something happens, and all of a sudden, factor 7A is activated, and that factor 7A also activates factor 10 to 10A. Once you form factor 10A, you have reached the common pathway. So the purpose of the intrinsic and extrinsic pathway is to form factor 10A. Once you form factor 10A, you have reached the common pathway. So at this point, you form factor 10A. That means we are done with the extrinsic pathway. So I'm going through again. So for extrinsic pathway, we said the trigger for the extrinsic pathway from the name extrinsic. So you need an outside force or trigger. And the trigger for extrinsic pathway is trauma. And once there's trauma, there's damage to the tissues. And these tissues release a substance called the tissue factor, also known as thromboplastin. Once tissue factor is released, tissue factor activates factor 7 to 7A. So 7 was inactive and has been activated to 7A. Once 7A is formed, it also activates factor 10 to 10A. Once you form factor 10A, we are done with the extrinsic pathway. So the purpose is to form factor 10A. Once you form factor 10A, we have reached the common pathway. Are you okay with the extrinsic pathway?
Yes, please.
Okay. So now let's talk about the intrinsic pathway. So for the intrinsic pathway, from the name, all that you need is from within. So intrinsic, you don't need an outside force like trauma to occur before the intrinsic pathway can be activated. So what happens is for the intrinsic pathway, the trigger for intrinsic pathway is endothelial injury. So when you have endothelial injury, and the endothelium is part of your body, so it's intrinsic, it's part of you. So when you have damage to the endothelial lining, being it smoking, being it hypertension, or anything that's causing damage to the endothelial lining. Once there's damage to the endothelial lining, what happens is there's activation of factor 12 to 12A. So whenever there is damage to the endothelial lining, there is an activation of factor 12 to 12A. And once factor 12A is formed, it also activates factor 11 to 11A. So once factor 12A is formed, it activates factor 11 to 11A. And once 11A is also formed, it also activates factor 9 to 9A. So there's activation of factor 9 to 9A, and this is done by factor 11A. So we are saying the intrinsic pathway, the trigger is endothelial injury. And once there's endothelial injury, there's activation of factor 12 to 12A. Factor 12A activates factor 11 to 11A. And we are saying 11A would also activate factor 9 to 9A. And once factor 9A is formed, factor 9A also activates factor 10 to 10A with the help of factor 8. So factor 9 activates factor 10 to 10A with the help of factor 8. So take note of that. There's activation of factor 10 to 10A with the help of factor 8. And once factor 10A is formed, we are also done with the intrinsic pathway. So if you look at the number of steps, you realize that you have a lot of clotting factors involved in the intrinsic pathway compared to the extrinsic pathway. So in terms of the pathway leading to clot formation, extrinsic pathway leads to clot formation faster than the intrinsic pathway.
Dr. Ishak.
Yeah.
Hello, doctor. Please, I lost you a little when you got to the factor 10A to factor 9, that part. Can you please take it again?
So I said for the intrinsic pathway, it starts with endothelial injury. Once there's endothelial injury, there's activation of factor 12 to 12A. And once you have activation of factor 12 to 12A, 12A consequently activates factor 9 to 9A. Sorry, factor 11 to 11A. So factor 12 will activate 11 to 11A. And once 11A is formed, it also activates factor 9 to 9A. And factor 9A activates factor 10 to 10A with the help of factor 8. So factor 9A activates factor 10 to 10A with the help of factor 8. And we are saying once you form factor 10A, we are done with the extrinsic pathway. We are done with the intrinsic pathway. That means we are in the common pathway now, because the purpose of the intrinsic and extrinsic pathway is to form factor 10A. So in both cases, they form factor 10A. You can have just the intrinsic pathway, or you can have just the extrinsic pathway, or you can have all of them interplay. Just that most at times, both of them are interplay because what will cause trauma also cause endothelial injury. So usually they are both interplay. All right. Now we are in the common pathway. For the common pathway, basically what is happening is there's conversion of prothrombin to thrombin. And thrombin is also known as factor 2. So the other name for prothrombin is factor 2. And the other name for thrombin is factor 2A. So we've reached the common pathway. Both intrinsic and extrinsic form factor 10A. So what factor 10A does is factor 10A helps convert prothrombin to thrombin with the help of factor 5. So there is conversion of prothrombin to thrombin, and this is done by factor 10A. And this factor 10A requires factor 5 to convert prothrombin to thrombin. So that is what happens in the common pathway. There's conversion of prothrombin to thrombin, and that is done by factor 10A with the help of factor 5. Once you have thrombin being formed, which is also known as factor 2A, thrombin converts fibrinogen to fibrin. So thrombin, which is factor 2A, also converts fibrinogen. And fibrinogen is the inactive form of fibrin. So it's converted to fibrin. So fibrinogen is converted to fibrin. And the other name for fibrinogen is factor 1. The other name for fibrin is for factor 1A. So the common pathway, basically prothrombin is converted to thrombin, and this is done by factor 10A with the help of factor 5. Once thrombin is formed, thrombin converts fibrinogen to fibrin, and fibrin is the final stage. That is what forms the fibrin mesh around the clot to stabilize it. So the fibrin mesh around the clot is the factor 1A. So that is done by that conversion from fibrinogen to fibrin is done by thrombin. Are you okay? Any questions? Yeah, so basically that is the clotting cascade. And the relevance of knowing this or we going through this is because when we get to the management and we are talking about factor 10A inhibitors, you know where they are acting. If we are talking about direct thrombin inhibitors, you should know where they are acting within the pathways. If we talk about vitamin K antagonists, that they are acting on vitamin K dependent clotting factors 2, 7, 9, and 10, you should know which pathways these clotting factors are. So that is the relevance of knowing the clotting cascade. All right. So now let's move on to talk about the clinical manifestation. So we will start with DVT. So if someone develops DVT, what are some of the signs and symptoms we expect to see if there is DVT? Anyone? Any signs and symptoms?
So the patient may experience swelling of the lower limbs and also pain.
Yeah. So there's usually swelling, swelling of the limbs, And this is usually the most specific symptom the patient would present with. So they'll tell you one of their legs is swollen. And once one of the legs is swollen, the first thing that should run through your mind is there any possible DVT? So you want to make sure that you rule out DVT, because if you don't rule it out and you are thinking maybe it's cellulitis or something and it ends up being DVT, the patient can develop PE from it. The patient can easily die. So always want to rule out DVT when someone complains of leg swelling. So leg swelling, most specific symptom. What again? You also mentioned pain. So the patient may experience pain in the affected limb. So pain or tenderness in the affected limb. What again?
Sometimes the affected limb, the swelling is warm to touch.
Exactly. So they may have warmth. Usually we use the term differential warmth. So differential warmth. What this means is that if one of the legs is swollen and you are suspecting that leg has, the patient has DVT on that leg, you may check the temperature to find out whether there's any differences in the temperature. So if you see one leg is warmer than the other, then that is a difference in the temperature. So we call it differential warmth. It could also be the same leg, but you realize that maybe around the thigh region is cold, but around the lower extremities is warm. Or the thigh is warm, but the lower, around the calf, around the shin area is rather cold. So when you have differences in temperature, we call it the differential warmth. So that is also one of the clinical manifestations you expect with DVT. Any other? Any other signs and symptoms?
There could be firmness of the affected leg.
You said there could be what?
Firmness.
Firmness. Did I hear you right? Firmness.
Yes.
Oh, okay. All right. So that can also happen, but it's usually not one of the common signs you expect to see. So that can also happen. What
Vein,
again?
vein distension.
Yeah. So you could also have um, the standard veins on the limbs. So you can see some visible veins because they are swollen. They become very visible on the legs. So you can get some distended veins, collateral leg veins in the affected limb. So that is also one of the signs and symptoms. What again?
Cynosed.
Yeah, so you could also have cyanosis. So cyanosis, where there's some bluish discoloration in the legs. So you could also have cyanosis. So that could also occur. Usually for the very severe DVTs, that is when you have cyanosis. So cyanosis can also occur. What again? So you talked about leg swelling. You
Hello,
talked
sir.
about pain and tenderness. Okay.
So please, I thought cyanosis will only occur with the arteries, or it occurs with the veins too.
Cyanosis can occur within the veins too. So
Okay.
typically, DVT wouldn't present with, most cases of DVT wouldn't present with cyanosis, except one particular type of DVT, and that
Okay.
can present with cyanosis. That particular type is known as phlegmasia ceruleus dolens. So phlegmasia ceruleus dolens. So typically, this is a massive iliofemoral DVT where there's a blockade from the iliac to the femoral vein. So you have thrombus within both the iliac and the femoral vein. And if it's a massive, extensive clot in there, sort of blocks almost all the lumen of the vein. So you may have some cyanosis occurring. So that is the only type of DVT that presents with cyanosis. So phlegmasia ceruleus dolens. So massive iliofemoral DVT. Aside that, the rest wouldn't present with cyanosis. All right. So you could also have reddening. So you could also have reddening of the skin at the area of the thrombosis. So if the DVT is within the thigh, you realize that the thigh has become reddish compared to the lower limbs. So you can have reddening of the skin around the thrombosis, and you could also have variable discoloration of the lower limbs. So some may appear pale, some may appear red, and all that. So you have this variable discoloration of the lower extremities. And you could also have differential warmth. So if you check the temperature, you realize some is colder, some are warmer, and all that. So that is differential warmth. And all these things that we are talking about, they tend to be unilateral. So they tend to be unilateral. So when you look at the two legs, you realize that all the symptoms are usually on just one leg. They affect one leg. So unilateral. So most cases are unilateral. That is not to say you can't have bilateral, but most of the times DVT affects just one limb. So most of the times it's unilateral. So take note of that. So if you are having bilateral leg swelling and all that, then it may be something else rather than DVT. But if it's just one, then DVT is highly suspected. So you would have to rule out DVT. All right. So these are some of the signs and symptoms. At times, the patient may be asymptomatic. So the patient may not have any signs and symptoms. So you may be doing Doppler to check something else, and you ended up seeing a clot within the legs. So you can pick it without the patient showing signs and symptoms. At times, too, the patient may be asymptomatic in terms of the leg manifestation, but the patient can have sudden symptoms that suggest P. So maybe they're having sudden shortness of breath, they are coughing, they are having blood in the cough and all that. The SpO2 keeps decreasing and all that. So they are having signs of P, but they don't have any evident leg swelling or tenderness or something. But they are showing signs and symptoms of P. So that could give you an idea to investigate further. So that these are the signs and symptoms we expect to see for someone with DVT. So because these signs and symptoms we just talked about are likely to appear in other conditions, you would have to take a lot of history, and you have to clinically examine the patient to be sure you are dealing with DVT. So the next thing we are talking about now is diagnosis. How do we diagnose DVT? So based on just the signs and symptoms, it's difficult because DVT can mimic a lot of conditions. So you tend to do history taking. History is the first thing you want to find out. And the history is based on the risk factors. So you want to ask the patient, have you been bedridden for more than 3 days? Do you take oral contraceptives? Do you have any chronic condition like cancer, nephrotic syndrome, or anything? Or have you had trauma or pregnancy or anything? So all these are things you want to find out from the history. So history taking is very important. Such that if the patient tells you, oh, I just traveled back from US, I had a long flight, and when I came back, I realized one of my leg is swollen. Then your thinking will be more tuned to DVT because patient had prolonged air travel, and immobility due to sitting is one of the risk factors for DVT. So because of that, you would have to really rule DVT out before you think of any other condition. So history is very, very important because it can give you a clue to what you are dealing with. So that's the first thing you do for the diagnosis. The next thing is you have to clinically examine the patient. So you want to find out whether there's unilateral leg swelling. So you want to observe the foot. You want to check the temperature of the legs, whether there is differential wounds. So all these have to be clinically examined by the doctor. Then there is also this bedside examination the patient, the doctor can do. We call it the Homan's test. Homan. So Homan, then Homan's test. So that is one of the bedside tests the doctor can check for. So usually the patients will lie supine in bed. While they are lying supine in bed, the doctor tries to flex the affected limb. So maybe if the right leg is the one that is swollen and he's thinking the patient has DVT on the right leg, he would raise the right leg and flex it towards the body. Once he flexes it towards the body, the patient will start complaining of pain in the affected limb. So whenever there is pain in the affected limb, once you try to flex the affected limb, that is known as the positive Homan's sign. The positive Homan's sign is for someone you are suspecting has DVT. If they lie supine in bed, with you flexing the affected limb towards the patient's body, the patient will start complaining of pain. And that pain is a positive Homan's test. That gives you an idea the patient may be having DVT, but it still doesn't confirm DVT. So the history taken, the clinical examination, all these doesn't confirm DVT. So the next thing you do is to check for the probability risk of the patient. And this probability risk for the patient, we use what we call the Wells score. So there's a clinical assessment tool to check whether the patient has a high risk of DVT or not. And this is what we call the Wells score. And basically, the Wells score, we have the Wells score and we have the modified Wells score. So we will go through them to know the parameters that are involved in the Wells score. But take note that the Wells score has 8 parameters, but the modified well score has 9 parameters. So we'll go through the parameters of the well score. Usually, I use the mnemonic best cap. So best cap, BESTCAP, best cap. That is the mnemonic I use to remember the parameters for the well score. So the B stands for bedridden for more than 3 days. So if the patient is bedridden for more than 3 days, you give a score of 1. If the patient has not been bedridden for more than 3 days, you give a score of 0. So the well score, there are parameters you'll be scoring. And these parameters, you give a score of 1 if it's present, a score of 0 if it's absent. So if the patient has been bedridden for more than 3 days, you give a score of 1. If the patient hasn't been bedridden for more than 3 days, you give a score of 0. The next thing in the best cap is E. The E stands for edema. So when you have edema of the affected limb, so you have edema of the affected limb, you give a score of 1. If there is no edema of the affected limb, you give a score of 0. So you give 1 for edema of the affected limb. If there is no edema, you give a score of 0. Then the S stands for the presence of swelling. So when you have swelling of the affected limb, so swelling of the affected limb, usually 3 centimeters larger than the other side. So when you have swelling of the affected limb, you give a score of 1. If there is no swelling of the affected limb, you give a score of 0. So that is for the S. Then the T stands for tenderness. So tenderness of the affected limb. So if you touch the place and the patient start complaining of pain and all that, that means the leg is tender. So if there's tenderness in the affected limb, you give a score of 1. If there's no tenderness, you give a score of 0. Then the C. So the C stands for collateral veins. So if you are seeing collateral veins, and these collateral veins, you are looking at the non-varicose veins. The varicose veins are the very big ones that are very much distended, appearing like a rope on the leg. But this one, you can have some collateral veins. These collateral veins usually form when there's a blockade. So they are trying to bypass the area of blockade. So you see some smaller veins, and these are collateral veins around the affected area. So when there's collateral veins around the affected area, you give a score of 1. If there are no collateral veins, then you give a score of 0. Then the A stands for active cancer, usually diagnosed within the last 6 months. So if the patient has had active cancer within the last 6 months, we give a score of 1. If there is no active cancer within the last 6 months, you give a score of 0. Then the P stands for paralysis or paresis. So if the patient has paralysis or paresis, we give a score of 1. If the patient doesn't have, you give a score of 0. So all in all, we have 7 parameters, right? But there's one most important parameter of the well score. That is the single most important parameter of the well score. And this most important parameter is alternative diagnosis other than DVT. So if you are thinking of any alternative diagnosis other than DVT, so if you are thinking it's more cellulitis than DVT, or is more maybe chronic venous insufficiency than DVT, or it looks like a bigger cyst than DVT, or lymphedema than DVT, you give a score of -2. So the moment you think it's more cellulitis than DVT, you have to subtract 2. You realize that all the parameters is either +1 or 0. But the moment you think it's more DVT than cellulitis, you give 0. But if you think it's more cellulitis than DVT, you'd have to subtract 2. So -2 for diagnosis other than DVT. So if you think it's more cellulitis than DVT, -2. But if you think it's more DVT than cellulitis, then you give a score of 0. So that is the single most important parameter of the world score. So meaning we have 8 scores or 8 parameters within the world score. All right. The difference between the world score and the modified world score is that the modified world score has 9 parameters. So it's the same parameters we've gone through, but the
Sir, please,
additional
can you
parameter is, so the additional parameter is that I'll go over. So for
Okay, sure.
modified world score, the additional parameter is previous history of DVT. So that's the additional parameter for the modified world score. So that one has 9 parameters. So aside the 8 parameters, we have a 9th parameter, which is previous history of DVT. So if the patient has developed DVT before, we said that is a risk for them to develop another DVT. So if they've developed DVT before, so previous history of DVT, you give a score of 1. But if there's no previous history, you give a score of 0. So take note of that. So all that I've been saying is, for the world score, there's a mnemonic we use, best cap. And B stands for bedridden for more than 3 days. If the patient is bedridden for more than 3 days, you give a score of 1. If they haven't been bedridden for more than 3 days, you give a score of 0. And the E, I said, is for edema of the affected limb. So if you check whether there is pitching edema or not, and there is pitching edema, you give a score of 1. If there is no edema, you give a score of 0. Then the S stands for swelling of the affected limb, usually around the calf. So swelling of the calf. You measure the calf size. Usually if it's 3 centimeters more than the other leg, then you give a score of 1. If there is no calf swelling, you give a score of 0. So swelling of the calf. Then the T stands for tenderness. So you try touching the affected limb and the patient starts complaining of pain. You give a score of 1. If there's no tenderness, you give a score of 0. Then I said the C stands for collateral veins. So if you have collateral veins on the affected limb, you give a score of 1. If there's no collateral veins, you give a score of 0. Then the A stands for active cancer within the last 6 months. The patient has developed active cancer within the last 6 months, you give a score of 1. If there is no active cancer, you give a score of 0. Then the P stands for paralysis. So if you have paralysis or paresis, you give a score of 1. If there is no paralysis, you give a score of 0. So that's the best cap. Then I said the single most important parameter, which is not part of the best cap, is alternative diagnosis other than DVT. So if you are thinking it's more cellulitis than DVT, you give a score of -2. But if you think it's DVT more than cellulitis, then you give a score of 0. And this is the single most important parameter because it can change everything. And you realize that is -2. All of them are +1 or 0, +1 or 0. But this is -2 or 0. So if you think it's more cellulitis than DVT, -2. But if you think it's more DVT than cellulitis, then 0. Then I said the difference between the modified and the WAR score is that modified has 9 parameters. And the additional parameter is previous history of DVT. If it's present, you give a score of 1. If it's absent, you give a score of 0. So these are the differences. And the other difference is the interpretation. So in the interpretation, for the WELL score, it's interpreted as a low probability, moderate. So after doing all the scores, you have to sum them to know whether it's low probability, moderate probability, or high probability. So that is how the WELL score is interpreted. So low probability, moderate, or high probability. But when you look at the modified WELL score, the modified WELL score is interpreted as DVT likely or DVT unlikely. So it's either DVT likely or DVT unlikely. So if you do everything and you get a score of 2 or more, then that is DVT likely. But if you get a score of less than 2, then that is DVT unlikely. So that is how the modified WELL score is scored. So DVT likely or DVT unlikely. And once you know the score for the patient, you can tell the next step to do, whether you'd have to move on to do D-dimers or you'd have to move on to do ultrasound. So it's more of an algorithm. So based on the WELL score is just to help you know the probability. But if the probability is, if the DVT is likely, then you know the test to do. If the DVT is unlikely, then you know you are trying to rule it out. So there are certain tests you have to do to rule it out. All right. Any questions on the WELL score?
Please, did you give the values for classifying the world score? Because I didn't get it. Sorry.
So I said for the interpretation for the modified WELL score, you are looking at DVT likely or DVT unlikely. So if the patient doesn't have any a score of more than 2, so 2 or more is DVT likely, less than 2 is DVT unlikely. So based on that, you know the next test to do.
Hello, sir. Hello.
Hello.
Yeah, please. The one you just gave, you said it was for modified WELL score, and then you said for the WELL score there is low, moderate, and high. So I want to know which the actual score that qualifies for low, moderate, and high.
Oh, okay. So usually when you get a score of around, so you can get 0, you can get 1, you can get 2, so you compile. So if you get a score of usually -2 to 0, it's low probability. Then if you are getting a score of 1 to 2, it's moderate probability, and 3 or more, high probability. So -2 to 0 is low probability, 1 to 2 is moderate.
Okay, thank you.
All right, any other questions?
Yes, sir, I have a question. Please, the last part that you're talking about, that is the alternative diagnosis, you ruling out cellulitis from DVT. How I understand it is that after doing the best cap, when you are done with your score, you now move to that. So with that one, is it that whatever score you get there, you add it to the best cap score, or how do you go about it?
So it's actually part of the parameters. It's actually part of, so you can make it best kappa. So best kappa A, the last A will be alternative diagnosis. So all the scores are +1 minus +1 or 0, +1 or 0. But the alternative diagnosis is -2 or 0. So if maybe, for instance, I got, because you have 7 parameters. So for the world score, then the last one is the alternative, making 8. So let's say you got 1, 1, 1, 1 for each of them. So you've gotten 7 points. When it gets to alternative diagnosis, the moment you think is more DVT compared to cellulitis, you add 0 to the 7, making 7. But if you think it's more cellulitis than DVT, then you'd have to subtract 2 from the 7, bringing your score to 5. Do you get it? So whatever you get for the best cap, when you get to the alternative diagnosis, is either +0 or -2. If you think it's more DVT compared to cellulitis, then you add 0 to the 7. If you think it's more cellulitis than DVT, then you subtract 2.
Sir, please, I have a follow-up question. So in this case where maybe you got your score of 7 and now you realize that it is more cellulitis than DVT. So you do the subtraction and you have 5. If we are looking at
Yes.
the various parameters I gave for the world, so that's the low, moderate, and high, it will still fall under the category of high. So in this case where now you are looking more at cellulitis, how does it relate?
So that is where we are now. So the world score doesn't confirm whether it's DVT or it's not DVT. So it's just a probability scoring system, just to know whether it's highly likely the patient has DVT, less likely the patient has DVT. So it's to help you know the risk probability for the patient. And once you've done that, because it doesn't confirm, the next thing is to move to other tests. So when you start DVT, the first thing is your world score. The world score, now we use the modified world score. That's the best because it incorporates previous history of DVT. So we'll stick with that one, the modified world score, the 9 parameters. And that one, we are looking at DVT likely if it's 2 or more, DVT unlikely if it's less than 2. So once you suspect someone has DVT, do the world score. So after the world score, you end up with 2 interpretations, either DVT likely or DVT unlikely. So if you use what we just said, you got a parameter of 7, then alternative diagnosis -2, that gives you a score of 5. So that means there are a lot of symptoms DVT, but in your more than what? DVT. So you have to do other tests to further confirm. So if you get DVT likely, DVT likely, meaning a score of 2 or more. You would have to proceed to do further tests. And once you get DVT likely, you have to do a bedside ultrasound. So you do a bedside ultrasound of the leg, so Doppler ultrasound of the leg to find out whether there's a clot in there or not. So the Doppler ultrasound is supposed to visualize the vessels in the legs for you to be sure whether there's a clot in there or not. So if you are getting what's called DVT likely, you proceed to do the Doppler ultrasound, and that would help confirm. So if you see a clot in there, then that's a positive sign for DVT. So DVT confirmed. But if there's no clot, then DVT has been ruled out. But on the other hand, if you get a score less than 2, that is DVT unlikely. So if it's less than 2, DVT unlikely, that doesn't rule out DVT. You still have to do other tests to further confirm or rule out DVT. So once you get DVT unlikely, which is a score less than 2, you have to proceed to do what we call the D-dimers. So there's a test called the D-dimers. And basically, D-dimers is the fibrin degradation products. So whenever you break down fibrin, you remember we talked about fibrin when we were talking about the clotting cascade. Fibrinogen is converted to fibrin, and fibrin is what forms the what stabilizes the clot. So whenever a clot is broken down, it means that the fibrin mesh or the mesh around the clot has been broken down. So when you break down the fibrin mesh in a process called fibrinolysis, you produce what we call fibrin degradation products. And these fibrin degradation products are known as D-dimers. So the purpose of checking for D-dimers is a reflection of the fact that there was a clot and that clot has been broken down. For that reason, the D-dimers are high. So whenever you have a clot and the clot is broken down, it produces fibrin degradation products, and these fibrin degradation products are called D-dimers. The thing about D-dimers is highly sensitive. So whenever there's even a small clot in there and it's broken down, D-dimers will be high. So in terms of sensitivity, D-dimers is highly sensitive. But in terms of specificity, D-dimers is not highly specific. So when you do D-dimers and D-dimers is negative, you are very confident that there is no DVT because it's highly sensitive. Whenever there's even some small clot in there, you do D-dimers and it's positive. It's telling you that there was a clot and that clot has been broken down, for which reason you're having elevation in the D-dimers. But it doesn't confirm the DVT because D-dimers can be elevated in other conditions. So it's not specific for DVT because it can be elevated in other conditions. And you could have pregnancy. Pregnancy can cause elevation in D-dimers. You could have cancer causing elevation in D-dimers. You could also have sepsis. When there's an infection, sepsis can cause elevation in the D-dimers. So all these conditions, so cancer, pregnancy, infections, when there's inflammation, all these can cause elevation in D-dimers. So for that reason, D-dimers is highly sensitive but not specific. So there's a term we usually use. So we say D dimers has a high negative predictive value, but a low positive predictive value. I'm taking it again. D dimers has a high negative predictive value, but a low positive predictive value. What this means is that when D dimers is negative, straight away it rules out DVT. We are sure that there is no DVT. So it has a high negative predictive value. So once it's negative, it rules out your DVT. But we are saying it has a low positive predictive value, meaning that once it's positive, it doesn't confirm DVT. It's not specific for DVT because it can be elevated in other conditions, of which we've mentioned pregnancy, cancer, sepsis, inflammation. When you have renal impairment, all these can elevate D dimers. Are you clear on that? All right. So when you do the wall score and you are getting a score less than 2, that means it's DVT unlikely. So if DVT is unlikely, the next test you should do is D dimers. If you do D dimers and it's positive, it confirms, it sort of tells you there is a clot in there that has been broken down, but it doesn't confirm DVT because it can be elevated in other conditions. But the moment it's negative, you know DVT is ruled out. So your ward score was DVT unlikely. We did D dimers and it's also negative. That means it further confirms that there is no DVT. So that patient doesn't have DVT. But if you do the wall score, DVT unlikely, and you do the D dimers and it's positive, a positive D dimers doesn't confirm DVT. It gives you an idea that the patient may be having DVT. So you need to confirm with the Doppler ultrasound. And once you do Doppler ultrasound of the leg and you see a clot in there, that's positive for the Doppler. So DVT is confirmed. But if you don't see any clot or you don't visualize any clot within the vessel, then DVT has been ruled out. If after the DVT, if after the ultrasound, bedside ultrasound, you still have a high clinical suspicion that this patient may be having DVT, even though your ultrasound is saying it's negative, you can wait for 4 to 7 days and repeat the Doppler ultrasound again. So if you still have doubt that the patient may be having DVT, irrespective of the normal Doppler ultrasound, you can repeat the ultrasound after 4 to 7 days. So that is how you diagnose someone as having DVT. Any questions? Any questions? All right, so basically that's how DVT is diagnosed. So the history is very important. Then you move on to the clinical examination. Then you do the wall score based on the probability, DVT likely, DVT unlikely. It can tell you whether to do ultrasound, Doppler ultrasound, or to do D dimers first, based on whether it's DVT likely or DVT unlikely. So that's how you diagnose. So it's confirmed by Doppler. That's the confirmatory test for DVT. All right, so if there are no questions, we'll end here for today so that in our next meeting, we'll start with the management. So we'll start talking about the various anticoagulants that are used.
Please,
Hello?
you said hi. You said that when the Doppler is negative and there's still a high suspicion of a DVT, repeat the Doppler after 4 to how many days? I didn't get the number of days. Sorry.
4 to 7 days.
4 to 7.
Okay. All right. Thank you.
Okay. Any other questions? All right. So,
I have a question.
okay.
Yeah, sir, please, do cholesterol levels play a role in the diagnosis of DVT? So if a person has, they say, high D dimer levels and then the cholesterol levels are high, will it raise your suspicion of a DVT?
So, in terms of diagnosis, cholesterol, the lipid profile doesn't have any role in the diagnosis of DVT. Just that when the lipids are high, we are thinking, is there any risk factor that can predispose these patients? But it doesn't have any direct correlation with the diagnosis.
Okay, thank you.
You're welcome.
Definition. Hello, sir.
Yeah.
Sir, please, what was the term you used for the massive iliofemoral DVT that presents with cyanosis?
So that's phlegmasia cerulea dolens.
Okay,
So
thank you.
phlegmasia cerulea dolens.
Thank you.
Okay. Any other question? All right. So if there are no other questions, we would end here. Hopefully, we'll continue with the management the next time we meet. Have a good evening.
You too. Thank you very much.
Okay. Thank you.